An antidepressant might cure the chronic, debilitating fatigue that comes with the long COVID syndrome. I heard that headline and my first thought was, oh, that's good. And my second thought was, wait a second. If an antidepressant is the cure for long COVID, does that imply that long COVID is just depression? I wouldn't be the first person to ask that question. Many studies have linked a history of depression and anxiety to the risk of long COVID, and the symptoms of long COVID, fatigue, brain fog, lethargy, overlap with those of depression. But there are clear differences as well. Studies have shown that some patients with long COVID have persistently elevated levels of inflammatory cytokines, microthrombi, mitochondrial dysfunction. We see unusual syndromes post-COVID as well, like postural orthostatic tachycardia syndrome, POTS, which you don't see in major depressive disorder. So what's going on? Does an antidepressant treat long COVID because at least some of long COVID is depression with a new name? Or is there something special about the antidepressant? Well, as it turns out, this is a very special antidepressant. The antidepressant of interest this week is fluvoxamine, which goes under the brand name Luvox. It's an SSRI, and the primary way it treats depression is the same way the other SSRIs treat depression, which is to say, at the level of the serotonin receptor and with generally modest efficacy. But fluvoxamine has two things that set it apart from the other SSRIs, and both are in play for why this drug might have a role in long COVID. The first, of all the SSRIs, fluvoxamine is the most potent stimulator of the sigma-1 receptor in the brain. The receptor, endoplasmic reticulum in brain cells, and stimulation through a series of steps leads to decreased inflammation. This may explain why fluvoxamine has some particular benefit over the other SSRIs in treatment of depression with psychosis. It's that anti-inflammatory property that got people interested in fluvoxamine. I wrote a piece on a trial in Brazil suggesting that fluvoxamine had some efficacy for reducing the severity of COVID-19. We're post-COVID now, but we're not post-long COVID, so enter this study appearing in the Annals of Internal Medicine, also from the same group in Brazil that did that other fluvoxamine study. Here are the details. Researchers enrolled 399 adults with long COVID, defined as persistent symptoms of fatigue lasting at least 90 days after a confirmed COVID infection. The fatigue needed to be moderate to severe, defined as a score of 4 or higher on the fatigue severity scale. That's a 9-item Likert scale shown here. The total score is just the average of the score on each item. Individuals with a confirmed diagnosis of major depressive disorder were excluded, but it's worth noting that people with depressive symptoms, just not the official diagnosis, were allowed to participate. The 399 individuals were randomized into 3 groups: fluvoxamine 100 milligrams twice a day, metformin 750 milligrams twice a day, or placebo. The treatment course was 60 days. At 60 and 90 days, the fatigue severity scale was assessed again, and here's where you get the headline finding. Fatigue improved across the board, but compared to placebo, the fatigue severity score was significantly better in the fluvoxamine group by about 0.5 points, which is considered a clinically meaningful improvement. That effect persisted even at day 90, 30 days after treatment stopped. The study monitoring board actually stopped the study early for efficacy. For what it's worth, metformin had no effect. The study monitoring committee stopped that arm for futility. So here we are, left with a fairly clear and relevant effect size. And the big question is, what is actually going on? Is the benefit of fluvoxamine due to the fact that fluvoxamine is fundamentally fixing something that is broken pathophysiologically in long COVID, brain inflammation or mitochondrial dysfunction or whatever it is? Or is fluvoxamine a band-aid, a mood-boosting drug in people who, whether clinically depressed or not, need a mood boost due to chronic fatigue? Now, I'm trying to triangulate the data here, arguing against fluvoxamine as a disease-modifying drug, the lack of metformin effect. The reason metformin was used in this trial is because it is thought to improve mitochondrial function and reduce inflammation, and that didn't change anything. What differentiates fluvoxamine from metformin is fundamentally its antidepressant effect. That said, if it's all antidepressant effects, we might expect that fluvoxamine would work better among individuals with worse depressive symptoms, no difference in effect size, regardless of baseline depression or anxiety. So maybe something special is going on here. Now, it's also worth mentioning that we've sort of seen this fluvoxamine story before, and it didn't pan out as well as hoped. Earlier, I mentioned that back in 2021, I covered the randomized trial from this same group showing a benefit of fluvoxamine for primary COVID infection. Well, subsequent trials in other countries, including the US, did not bear that benefit out. This happens. No one study is definitive after all, but it certainly gives me pause. I'd like to see some replication before we reach for fluvoxamine for long COVID fatigue. There's a final issue that comes up when we think about what makes fluvoxamine special among the SSRIs. Sure, there's the sigma-1 effect that theoretically reduces brain inflammation, but there's something else. Fluvoxamine, among all the SSRIs, is the most potent inhibitor of the liver enzyme CYP1A2, an enzyme that is responsible for breaking down, among other things, caffeine. That's right, fluvoxamine dramatically increases the half-life of caffeine from 5 hours to over 30 hours. In a study where the primary outcome is fatigue, this seems like a potentially important mechanism. It was not explored in the paper. Of course, in the end, the mechanism of benefit is somewhat of an academic question. For people suffering from extreme fatigue in the aftermath of a COVID infection, the reason the drug works may be less important than the fact that the drug works. For Medscape, I'm Perry Wilson.